Hi everyone, it's Dr. Harrington. We are on Hospice Part 3 of our series, and this is going to cover the questions of who pays for hospice, and what does hospice cover? What services does hospice provide? So let's start with the first question. Hospice was originally created as a Medicare hospice benefit. So anyone who in the United States who has Medicare, which is everybody over the age of 65, automatically has the Medicare hospice benefit. So that is where hospice was originally structured. What came a little bit later was the Medicaid hospice benefit, and then the hospice benefit is provided by all major payers when it comes to private insurance. So I'm going to go kind of from the top. The Medicare hospice benefit is the most well defined, and usually when Medicare makes a change to their hospice benefit, something is added, something is taken away, that sends a message to most of the other payers to do the same. So if you know everything about the Medicare hospice benefit, you can know everything pretty much you need to know about the Medicaid hospice benefit, what private insurance covers, and the uninsured. So we're going to kind of suss out the Medicare hospice benefit in the next few slides. The only thing you probably need to know about the Medicaid hospice benefit is if you have Medicaid, not only will you patients will receive everything that's listed in the Medicare hospice benefit. Those things the two look very similar. Medicaid patients can also apply for an additional aid to come into the house for so many hours a day. So Medicaid patients, if you qualify for Medicaid, will get some additional aid support in the home. Private insurance, what you need to know about this is every private insurance company is a little bit different. And so some will look very much like the Medicare hospice benefit. Some will have a copay to their hospice benefit. Some will have a cap to how much they'll pay towards hospice. So what I recommend is for patients who are under the age of 65 who do not have Medicare, who have like a private insurance like Blue Cross Blue Shield or another private insurance, that the social worker or the case manager needs to call the private insurance and make sure that the family knows what the insurance will pay for. What I don't like is for families to be surprised with a copay or to find out 2 months later that they've reached their cap on their private insurance. So it's always good to know up front what the insurance will pay for. And then the last category is that of the uninsured. Per hospice rules, when you look at the hospice benefit and the law, it says that no one will be turned away for inability to pay. So what hospices usually do is they will have a fund set up for indigent care. So oftentimes hospices will do fundraisers and things like that. So even patients who are uninsured, who do not have a pay source, hospice will enroll those patients and pay for them in another way. So no one should be turned away for inability to pay. So Medicare hospice benefit, let's kind of talk about what that looks like. So patients who are over the age of 65 are automatically enrolled into Medicare, and this includes the Medicare hospice benefit. It's not something special that you have to sign up for. Everybody has this. So Medicare Part A is the part that pays for hospitalizations. Medicare Part B is usually the part that pays for outpatient clinic visits. You remember your Part D is for drug cost. So in theory, when a patient is enrolled in home hospice, you shouldn't be coming back and forth to the hospital. You really shouldn't need that Part A anymore. So when a patient enrolls in hospice, the Part A benefit of the Medicare shifts and now becomes the Medicare hospice benefit. Now, let's say a patient decides after 3 weeks, you know what, I don't want hospice after all, I want to disenroll from hospice. That is really no big deal. It just shifts back to Medicare Part A. It's a very, very seamless transition. So let's talk about routine home care. So we learned about routine home care in Part 2 of our our PowerPoints. So what is included in routine home care? This is what most patients receive when they enroll in hospice, because most patients are staying at home or are in a nursing home. So what routine home care, the things that are covered are case oversight by a hospice team. You have one team that takes care of the patient that includes one physician. So that physician is called the hospice medical director. And the hospice medical director is typically the one who oversees the care of the patient. Now, a patient may select another doctor to oversee their care. So if you've been taking care of a patient and you're the primary care doctor and you've cared for this patient for 20 years and the patient says, you know what, I want my primary care doctor to be my hospice doctor, that is perfectly fine too. So patients can select other doctors to be their physicians and oversee their care. I would think that most patients have the hospice medical director as the main doctor taking care of them. So they don't have to go to a PCP and several subspecialists. There is one doctor that takes over their whole care. Uh, the Medicare hospice benefit pays for nursing care. So this is where a nurse will come to the patient's home and do home visits at least once a week, and sometimes more than that, depending on what the patient needs. But there is a minimum visit by a nurse who comes and assesses the patient, goes over medication management, and communicates to the hospice medical director and helps with changes. The Medicare hospice benefit pays for patients to have access to a social worker. Sometimes the social worker can go to the patient's home and help with things like FMLA, counseling, those kind of things. Counseling services, all medications related to the terminal illness, and rules have changed over the last few years about what medications are covered and which ones are related or not related to the terminal illness. But the way the rules read right now is if the patient is taking a medication that is any way, shape, or form related to the terminal nature of their condition, that the hospice has to pay for it. So for example, if your hospice diagnosis is metastatic breast cancer, but you also happen to have type 2 diabetes, is the type 2 diabetes contributing to the terminal nature of your illness? Probably so. And so because it falls under that umbrella, the hospice also has to pay for that medication. Durable medical equipment, if patients need a hospital bed or a bedside commode or oxygen or a number of things, the hospice will pay for that and have that delivered to the home. A home health aide is very, very helpful. Many can come up to 3 days a week and help with feeding and baths and some light things around the house. Hospice will give you access to speech therapy, nutrition therapy, PT, OT, especially in specific situations where the patient might need something extra at home. And then bereavement support. So families will receive bereavement services and bereavement support for up to 13 months after the patient dies. So all of this is covered under the Medicare hospice benefit. Again, Medicaid, insurance, it looks very, very similar to this. We talked about these locations of care or levels of care in the last module. So the Medicare hospice benefit also pays for inpatient hospice or a GIP bed. So remember, these are short term. They are for pain and symptom management for symptoms that patients are unable to manage at home, usually very short term. Medicare hospice benefit also pays for short term respite care. Again, this is up to 5 continuous days. The families often just need a break, and this is a really nice part of the benefit. And then, and for those very rare selective cases, if the patient qualifies for something like continuous care, that is also covered under the MHB. All right, so hospice is reimbursed in a very unique way, and it's called per diem reimbursement. So the hospice company, the hospice organization, will receive a set amount of money from Medicare, from the government, per patient per day. So for routine home care, the hospices will receive about $190 per day, and this is per 24-hour period for patients to receive routine home care. So just remember, that was all of this for less than $200 a day. This is actually a very good deal. That's a lot of services for not that much reimbursement. And so hospices have to be very creative about how to provide the care that patients need. So routine home care, it's about $190 per day per patient. General inpatient care, where patients go to an inpatient center and get around the clock care from a hospice, the reimbursement's about $1,000 a day. Inpatient respite care, it runs about $450 a day. And then continuous home care is the most expensive, when you have to hire a nurse to be at the bedside 24 hours. So that's about $1,350 a day. And again, these can vary by where you live. Do you live in a rural area versus an urban area? Different parts of the country have different reimbursements, but gives you about an estimate. So why is this important that you know? I think it's important to know just how the reimbursement is set up. So, um, so how does this work exactly? I tried to put this as simply as possible. So the hospice gets a per diem, a set amount of money per patient per calendar day, and it all goes into a giant bucket. Okay. And then out of that bucket, the hospice medical director can allocate that money to each individual patient as to what they need to take care of the patient. So for example, there are some patients, let's say we have a patient with end-stage dementia who lives at home, and she has 4 daughters that are taking care of her around the clock. She doesn't take but 2 medications. She doesn't need any durable medical equipment. For this patient who has a lot of help at home and who is not really taking a lot of expensive medications or has a lot of DME needs, that patient may only need $50 a day to take care of that patient adequately. Now, if one of my patients that I send from palliative care clinic and the Cancer Institute goes home with hospice, this may be a patient who is on expensive pain medicines. What if that's a patient who needs a PCA pump at home and oxygen and some expensive medications and a hospital bed and needs extra aids? So all of those things, that patient may take, I don't know, $500 a day to adequately take care of. If you have a pretty large hospice and taking care of many, many patients, you have a big bucket. And so that hospice medical director can absolutely give great care to the patient who doesn't take a lot of money to take care of, and give great care to the patient who needs a lot more than the per diem. So big bucket, hospice medical director uses that, that's appropriate for patient care. I can tell you that most hospices are not for profit. They just barely break even. This is not a huge money-making operation. Um, this is not that much to provide really excellent care and to provide all of these things for patients to receive excellent end-of-life care. Hospices do a really good job with what they have. All right, so what is usually not covered? So things that are very aggressive interventions and kind of not in line with end of life and comfort. So for example, chemotherapy. Um, so if a patient wants palliative chemotherapy and hospice, while that's not a philosophical problem, I don't think any hospice would have a philosophical problem with that, especially with immunotherapy and those that are fairly easy to take. It's just that many of these drugs cost $30,000 a month or something really outrageous. With $190 of per diem reimbursement a day, most hospices just can't cover those expenses. And so usually for patients, if they are wanting things like palliative chemo or palliative radiation or a procedure or a surgery or something like that, that's going to be very expensive, that I know the hospice is not going to be able to cover, even though philosophically I don't see a problem with that, because the intervention is palliative. The hospice just won't be able to do it. So usually what I do is I try to get those more aggressive things prior to the hospice enrollment, just so the hospice can cover those expenses for the patient. Um, things Other things that are not covered is nursing home room and board. This one is really hard for families to wrap their heads around. This one's really tough, okay? So what a hospice will pay for are these things, right? So these routine home care, all of these things, that's what the hospice reimbursement pays for. Um, all these things can be delivered to the nursing home. What is not paid for is nursing home room and board. So let's just review really quickly, especially for the students that are on this. How is nursing home paid for? You guys should know this. So, but we'll review anyway. So one way that nursing home is paid for is out of pocket. I would say that that's the majority of families pay for nursing home room and board out of pocket. It's usually anywhere from $5,000 to $7,000, sometimes more, depending on what kind of nursing home it is. Most families will pay for nursing home room and board out of pocket. The second way to pay for nursing home is through long-term care insurance. If a patient is fortunate enough to have paid into long-term care insurance, they can use their long-term care insurance to pay for the nursing home room and board, and then their Medicare will pay for the hospice services. The third way is if patients have Medicaid. So if a patient has Medicaid, Medicaid does pay for nursing home room and board. And so if a patient has Medicaid and hospice, that's really the only scenario where Medicaid will pay for room and board and for the hospice services. Or some patients have Medicare and Medicaid. Medicaid pays for the nursing home room and board. Medicare pays for the hospice services. The fourth way that a nursing home is paid for is through the Medicare rehab benefit. So Medicare will pay for X number of days of a rehab bed at a nursing home. And the goal is to rehab, right? The goal is to get better. So for Medicare to pay for hospice and a rehab bed doesn't make a lot of sense to Medicare. They will pay for one or the other and not both. And this really can leave this is a big gap in the healthcare system, unfortunately. So oftentimes we will have patients whose family just can't take care of them at home. They work, there are limitations there, and the patient does not meet criteria for general inpatient hospice. They don't have symptoms that can't be managed at home. Well, all that we are left with is nursing home with hospice. And this makes it very difficult if families don't qualify for Medicaid. They've got to find a way to pay for nursing home out of pocket, which is really difficult for most families. So just remember the per diem reimbursement is unique with hospice, and just understand that yes, there are some limitations for what hospice can provide, not necessarily because there's a philosophical problem. It would be great to be able to pay for room and board and more aggressive palliative treatments. Unfortunately, because of the per diem reimbursement, we are limited as to what hospice can pay for. All right, why do I need to know this? Families will ask. This is the very first thing that they ask for. Now, do you need to know all the details? No, but you need to know some broad strokes so you don't make any promises to families that you can't keep. So what I recommend is making sure that the families can talk to one of your social workers or case managers, or even someone from the hospice that can go out to the house or come to the hospital and talk to families about what hospice covers and how things are going to be paid for. And then the next thing, the reason why you need to know this is because of timing of enrollment. Again, there are some patients where it is really appropriate to get 5 days of whole brain radiation because it will help them symptomatically. But if the patient is ready to enroll in hospice, I'll say, all right, well, let's get that 5 days of whole brain radiation, and then we will enroll in hospice on day 5 after your last treatment. And that's because I know that most hospices won't be able to afford the radiation. So again, this may affect the timing of enrollment. The other thing that it's good for physicians to know is there are some medications that vary widely in cost, but that work about the same, that have the same effectiveness for patients. So for example, if I send a patient home with with hospice and I order Emend for an antiemetic. Emend is a good drug. There's nothing wrong with it, but it's pretty expensive. And you can almost be sure the hospice medical director or the nurse will call me and say, Dr. Harrington, I see that you ordered this medication for the patient. What do you think about Compazine or generic Zofran? Can we try one of those first? And this is because we're trying to get the cost down as much as we can while still providing effective care. And I may say, you know what, Zofran is going to work just as well. Why don't we order that? Okay. So in review, how hospice is paid for, mostly through the Medicare hospice benefit for patients over the age of 65. They all have the Medicare hospice benefit. For those under the age of 65, Medicaid will pay for hospice plus some additional services. Every insurance company has a hospice benefit. I recommend that you or your nurse or your social worker call the insurance and make sure that the family is aware of all of those details. And then hospices will pay for uninsured patients through donations. We also went over what is involved and what the benefit pays for routine home care, for general inpatient hospice, for respite, and for continuous care. And then lastly, it's important to know that hospice is reimbursed with a per diem reimbursement system, which really does affect the kind of orders and the kind of care that you want to order for your patient. You just have to be aware of that. And for the most part, even if patients require more than $190 a day, usually because of how it's set up, the hospice organization can shift things around and pay for what every patient needs, because every patient may not need the same thing. Okay, that's all I have today. And we will have one more um, module with frequently asked questions. All right, so thank you very much.